Welcome to the first session of the Pathomorphology tutorials. All right. Now we have multiple oval ulcers along the intestine were revealed on autopsy of a person who died from a diffused peritonitis in the distant part of the small intestine. The bottom part of the ulcers are clear, smooth, formed with muscular or serous covering. Edges of the ulcers are flat and rounded. There are perforations of up to 0.5 centimeters in diameter in two ulcers. What disease can be diagnosed? What disease can be diagnosed? What disease can be diagnosed? So basically, over here, you are, or first of all, you must know what, of course, you know what cholera is all about. In cholera, there's usually what diarrhea and stuff like that. So one way by which somebody can die out of cholera is when there's what severe dehydration. When there is severe dehydration. Now, in dysentery, it's simply an intestinal inflammation which normally affects the colon. It affects the colon. And we can have, how do you call it? We can have irritable bowel disease and irritable bowel syndrome. In Krok 2, I cleared out the differences between irritable bowel disease and irritable bowel syndrome, where in syndrome, there's no organic changes to the mucosal lining. No organic changes to the mucosal lining, but there is diarrhea and there can be vomiting as well. But in irritable bowel disease, there is a mucosal changes. There is a mucosal changes. So obviously, we can rule out all of these things. Now, one of the things that you must know about salmonellosis is that actually salmonellosis is another name for salmonellosis is actually the typhoid fever. Okay, it is caused by the parathyroid typhi and then typhi, parathyroid typhi. Yeah. So this organism or this disease normally causes peritonitis in the body. Now, when we say peritonitis, we're referring to kind of the whole of the abdomen having what? Tenderness. The whole of abdomen having tenderness. Having tenderness. So the body, you can't even touch it. If you touch it, there is pain. If you touch it, there is pain. And usually how we can see this peritonitis is when we do an x-ray, we will see it under the hemidiaphragm on the right side. On the right side, hemidiaphragm, you will see some fluid formation over there. That shows that the perforation has gone deep. It has gone deep. It has gone deep. And like I said, that is one of the major causes of peritonitis or a diffuse peritonitis. It means that there is a perforation. There is a perforation. So over here, we are thinking of a typhoid fever or salmonellosis. We are thinking of a typhoid fever or salmonellosis as the cause. Of course, tuberculosis, we know it has to do with the lungs. Of course, it can affect the GI system and even the spine and things like that. But this is definitely not a tuberculosis. This is definitely not a tuberculosis. We are thinking of a typhoid fever. Typhoid fever. Why? Because there is signs of diffuse peritonitis and perforations. This makes this typhoid fever. Typhoid fever. And in some question, they will tell you that it is found in eggs, it is found in milk. All of these things, take note of them. The egg and in the milk, you can find typhoid. You can find salmonella over there. You can find salmonella over there. So here you are thinking of typhoid fever. Typhoid fever. All right. I took my time to explain that question because it sounds confusing. If you don't take care, you might miss it. But like I said, for typhoid fever, you are dealing with what? Peritonitis, and you are dealing with perforation. Please write it down. Okay, patient suffering from trombophlebitis. That means there's a problem in the vein or thrombus in the vein or inflammation of the deep vein of the lower limb. of the lower limb, you see, of the deep veins suddenly died. Suddenly died. Now, autopsy has shown freely lying red friable masses with dim grips surface in the trunk and bifurcation of the pulmonary artery. Now, one of the complications of trombophlebitis is that it leads to what we call thromboembolism. It leads to what we call thromboembolism. When we say thromboembolism, thrombus is like a clot that has formed inside a vessel. When this clot breaks, it begins to undergo what we call embolism. So embolism is actually the movement of a clot from its place of origin to a different location. That is what embolism. So we say thrombo. In other words, the clot is moving. Thromboembolism. And usually it goes to affect the lungs. So sometimes we call it pulmonary thromboembolism. Pulmonary thromboembolism. And that is the cause of death in this patient. Thromboembolism. Like you said, you see over here, they say what? Embolism with foreign body. That is when the foreign body is moving. Now, when you hear of fat embolism, it has to do with what? Fracture. Fracture, where a bone or a piece of bone will break off and go and lodge in the lungs or go and lodge at another place. That is fat embolism. So basically, we are dealing with thromboembolism. We have an examination of a patient revealed a dense, movable skin tumor that is standing out distinctively from the surrounding tissues. It is standing out distinctively. Its section is found to be what? White and composed of fibrous tissue. Fibrous tissues. What tumor is it? What tumor? They've told you the origin of this tumor. They said it is composed of what? A white, and it is found to be white and composed of a fibrous tissue. Fibrous tissue. So definitely you're thinking of what? Of a fibroma. You are thinking of a fibroma. That's why I said from Pathomorph, sometimes you will see the answers in the question. You will see the answer in the question. So this is definitely what? A benign tumor that is composed of the fibrous or a connective what? Tissue. Fibrous or a connective tissue. And we have types of fibroma. In subsequent questions, you will see them. Maybe not today, but another time you will see this question like hard fibroma, soft fibroma. When we get there, I will lay out the differences between the hard fibroma and the soft fibroma. In fact, let me just mention it for you. With a hard fibroma, it consists of many, many fibers and a few cells. Many fibers, few cells. Now, in soft fibroma, it consists of many loose connective cells and less fibrous tissue. Many, so you're talking about many cells and then less fibrous tissue. So that is what the exact opposite of what? Hard fibroma. That is just by the way. So please take note. When we get a question like that and we say it, you will just understand it better and appreciate it. So here we are thinking of what? A fibroma. We have a 50-year-old man that felt vague abdominal discomfort within 4 months. Physical examination revealed no lymphadenopathy, no abdominal masses or organomegaly at palpation. The bowel sounds are heard. Abdominal CT shows a 20 centimeter retroperitoneal soft tissue. Retroperitoneal soft tissue. These are soft tissue. Soft tissue. These are fats. These are what? Fat cells. Fat cells. A mass occurring at the left psoas what? Muscle. A stool specimen tested for occult blood is negative. What neoplasm is it? What neoplasm is it? So definitely they are telling you we're having what? A 20 centimeter retroperitoneal soft tissue. These are fat cells. So definitely you are thinking of what? Of a lipoma or a lipoma. You are thinking of a lipoma. Lipoma. So here your answer is what? Is A. Again, your clue here is what? The presence of a retroperitoneal soft tissues. These are soft tissues. Okay. Of course, the common locations are the upper back, the shoulders, and the abdomen, because these places have a lot of what? Fats over there. The abdomen, the shoulders, and then the upper back. The upper back. And they are usually movable and then painless. They are painless. That's why they are benign. All right. Great. We have a 40-year-old woman had a feeling of abdominal discomfort for about 8 months. On pelvic examination, there is right anexial mass. Okay. CT scan demonstrate cystic mass. There is a cystic mass involving the right ovary with small areas of calcification. The uterus is normal, fallopian tube, and the ovary has been removed surgically. Okay. Grossly, the mass on sectioning is filled with abundant hair and sebum. Abundant hair. Microscopically, the mass has glandular spaces lined by columnar cells, squamous epithelium with hair follicles, cartilage, and dense connective tissue. What kind of tumor is it? Now, a tumor that is made up of several different types of tissues, such as hair, muscles, teeth, or bone, is called a teratoma. It is called a teratoma. So over here, they're just describing a teratoma. A teratoma. So what then is a teratoma? A teratoma is a tumor made up of what? Different types of tissues, such as hair, follicle, hair, muscles, teeth, or bone. So if you see that there's a tumor of all these places all occurring at the same time, then we are thinking of a teratoma. And they typically are formed in the ovaries, the testicle, the tailbone, and less commonly in other places. Less commonly in other places. So over here, we are thinking of a teratoma. And of course, one of the complications of teratoma is ovarian torsion, testicular torsion, or hydrops fetalis, and so on and so forth. So here we are thinking of a teratoma. All right. And of course, the question is saying that we have hair, we have sebum, we have connective tissue, we have cartilage, we have Please, everything is pointing towards teratoma. A man died 8 days after the beginning of the disease. He was diagnosed with dysentery. At the autopsy, it was found out a thickened wall of the sigma and rectum, fibrinous membrane on the surface of the mucous membrane. Histologically, there is a deep necrosis of the mucous membrane with infiltration of necrotic masses with fibrin. What kind of colitis? Remember when I mentioned about dysentery, right? When I started talking about irritable bowel syndrome and then irritable bowel disease, and I told you that in irritable bowel disease, we have a problem with the mucosal lining, and one of it is colitis or ulcerative syndrome. Okay, ulcerative colitis, and we have the Crohn's disease. So over here, we are talking about irritable bowel disease. To be specific, we're talking about what? Colitis. Now, the question now is that what kind of colitis does this thing or these changes correspond to? So first of all, this talks about the type of exudate. Exudate. And an exudate is any fluid that filters from the secretory system into lesions or areas of inflammation. I repeat, it is any fluid that filters from the circulatory system into any lesions or areas of inflammation. And morphologically, we can distinguish the following type. So if I were you, I'll write it down. We have the serous type. The serous type. Now, this is when the exudate resembles the serum, or it is watery, or it is clear. So when the exudate is watery or it is clear, we call it serous. Serous. Then we have fibrinous. Fibrinous. So in fibrinous, the exudate is of fibrin content. It is of fibrin content. But look at it over here. We said the mucous membrane with infiltration of necrotic masses with fibrin. So over here we can think of what? A fibrinous. A fibrinous. A fibrinous. But in fibrinous, we have two kinds. In fibrinous, we have two kinds. We have Krupos, that is easily removable, and then we have diphtheric, that is not easily removable. Again, with fibrinous, we have what? We have two types. That is a Krupos, which means it is easily removable, and then we have diphtheric, which means it is not easily what? Removable. So when this exudate or this mass can actually be removed, we call it what? We will call it Krupos fibrinous. But if it is not easily removed, we call it what? Diphtheric fibrinous. Now, the other types include purulent, which means there's what? A suppurative exudate. That is the formation of a pus or a pus. A pus. That's the right word, the pus. And then we have hemorrhagic, when it involves a vascular damage. When it involves a vascular or a vessel damage. Then we have catarrhal, where there's an increase in production of mucus. Increased in production of mucus. So over here, obviously, we are thinking of a fibrinous. But what type of fibrinous? Now, I've taken my time to explain these things because we are going to meet them again. We are going to meet them again. So when we meet them, we'll just be revising. Okay? That's why I'm taking my time to explain all these types of exudate for you to understand. So now over here, they didn't really mention that it is easily removable or not. However, we have nothing to confuse us. This is definitely what? A diphtheric type of fibrinous exudate. A diphtheric. Why? Because they are telling us that the mucous membrane were infiltrated with what? With necrotic masses and with fibrin, which is what? Fibrinous. Fibrinous. So here we are thinking of what? A. We are thinking of A. In catarrhal, there'll be what? Increase in mucous membrane. I mean, increase in mucus. Increased production of mucus. So here we're thinking of A. And in gangrene, you know gangrene too. Good. A woman is suffering from dysfunctional metorrhagia was made a diagnostic abortion. Histologically, in the script, there were a lot of small stamped glandules covered with multiwoven epithelium. Look at this. A lot of glandules covered with multiwoven epithelium. Now look at it. The lumens of the glandulars were cystically extended. That means it has been enlarged. Choose the variant of general pathologic processes. Look at it. First of all, they are saying that they have what? A lot of what? Glands. Again, there are cysts, and again, they are enlarged. Cysts, cystically enlarged, meaning there's a cyst has what? Enlarged. And we have what? Glandulars. Or you look at here, a lot of what? Glandulars. So what are you thinking about? Without wasting my time, not understanding anything, simply put, these are what? Glandular cystic hyperplasia of the endometrium. Of the endometrium. So no need to find out what it means. Everything is in the question. And that is what is called morphology. They describe the pathology. So you have to just know what is being described. And then you give it the name. Okay. So basically, you are thinking of a glandular cyst hyperplasia of the endometrium. So here, your answer is A. Now, endometrium is simply the inner lining of the uterus, of course, of the uterus. Good. A 46-year-old man complains of difficult nose breathing. Mucolish cells are there. Storage of epithelial cells, plasmocyte, lymphocyte, hyaline balls are discovered in the biopsy. What is the most likely diagnosis? So this is a specific granuloma. And again, I want to educate us on the different types of granulomas that we can find. And I'm doing this because this is our first lecture on pathomorphology, and I want you to understand the basis. When you understand these things, we're going to see a lot of questions on them later on. So please, if I were you, I will write this down. Now, in leprosy, you will see what we call lepra, or leprosy is the same as what? Lepra. And usually, a lepra is composed of what we call leprous Virchow cells. Leprous Virchow cells, or the Virchow cells. No, it's Virchow cells. That's VIRCHOW. Yeah, VIRCHOW cells. Leprous Virchow cells. So this is specific for what? For leprosy. This is specific for leprosy. So you can write it down. Specific for leprosy. Good. Now, in what we call rhinoscleroma of the nose, it is characterized by the presence of scleroma. Scleroma. That is rhinoscleroma. It is characterized by the presence of scleroma. And a scleroma simply means we have plasma cells, epithelial cells, lymphocytes, and hyaline spheres or hyaline cells. That's what scleroma really means. Good. Not only does it contain scleroma, it also contains mucolish cells. Again, rhinoscleroma contains scleroma and mucolish cells. So sometimes in the question you will see a patient is diagnosed as rhinoscleroma. What can you see in the option? So in the option you're thinking of what? Either mucolish cells or scleroma. Why? Because they said what? The person is suffering from what? Rhinoscleroma of the nose. So please write it down. Now in tuberculosis, it is characterized by a central necrosis. Surrounded by epithelial cells, lymphocytes, plasma cells, and giant Langhans cells. Langhans, LANGHANCE cells. Langhans cells. Now we also have syphilis. So in syphilis, we see what? Gumma cells. That's GUMMA. Gumma. In syphilis, you will see gumma cells. So ladies and gentlemen, these are just the summary of all these specific granulomas that you need to see. Now, I've already explained. If you are seeing mucolish cells and you are seeing epithelial cells, plasma cell, plasmocyte, lymphocyte, and all these are actually referring to what? To scleroma. All these refers to what? Scleroma. And that means that this patient is suffering from what? Rhinoscleroma. So here your answer is what? Scleroma. But the disease is what? Rhinoscleroma. Please take note. Now, I've given you this because we'll talk about them in subsequent lectures or presentations. So please write it down and then learn it. Good. Now we have extensive thromboembolic infarction. Again, you have seen your guy, thromboembolic. That means it is going on to affect the what? It can affect the what? The heart. That is what infarction. But that is so it has moved from the heart. Now look at where it is going. There's infarction of the left cerebral hemisphere. So that means that this is not really about the heart, but what? About the brain. About the brain, the cerebral hemisphere. There is large septic spleen, immunocomplex glomerulonephritis, ulcers of the edges of the aortic valves. In fact, the heart has even been involved. Covered with polypus thrombus with colonies of staphylococcus were revealed on autopsy. What disease caused the cerebral thromboembolism? Now you must know that. So what disease is causing the cerebral thromboembolism? And one of the things that staphylococcus can cause in a person is what we call endocarditis. Endocarditis. These are one of the things that these staphylococcus can cause. It can cause what? Endocarditis. In other words, we call it septic bacterial endocarditis or infective endocarditis. And this is simply an infection that is caused by what? The bacteria called what? Staphylococcus. And of course, sometimes by what? Streptococcus. And how does it happen? It enters the bloodstream. It enters through the bloodstream and settles in the heart lining. And you know, endocardium has to do with the heart lining or the lining of the heart. So basically, that is the mechanism of action for the cerebral thromboembolism. So first of all, it will enter into the heart. And don't forget, if it enters into the heart through the lungs, it can be sent back and it will enter into the brain. Okay? It can enter the brain, or directly it can move from the lower limb and straight it goes into what? Into the brain. But always it must enter through what? The right heart. It must enter into the right heart. And when enter into the right heart and it carries all these staphylococcus, because they are telling us that the thrombus were having colonies of staphylococcus. They were having colonies. I mean, they were having they carried along with themselves with staphylococcus. So not just the thrombus was there, but also what? With this what? Bacteria. And all of them will move into the what? The heart. And that can affect the heart what? Lining. That is called the what? The endocarditis or inflammation of the inner lining of the heart. So basically, what is the cause of this cerebral thromboembolism is what? Is infective endocarditis, also known as septic bacterial endocarditis. So this we are referring to D. All right. A patient is ill with diabetes mellitus, felt acute pain in his right foot. Guys, do you know that people who have diabetes usually develop a lot of ulcers? They develop a lot of ulcers. Okay. Now, objectively, the foot thumb is black. Foot tissues are edematous. And there are foci of what? Epidermis desquamation, stinking discharges. What are you thinking about? What necrosis is it? Definitely you're thinking of what? Of a gangrene. But is it dry or wet or moist? Of course, they are thinking that there's black foot tissues with edema. Edema means fluid. So that means that this is what? A moist gangrene. And a gangrene is simply a type of what? Necrosis. It is a type of necrosis. And it's the most common cause of it is found in the lower extremities. And sometimes the uterus and then the lungs. You can see them there. Okay. And then we have three types of gangrene. We can talk about the dry, the wet, or the moist. And we have what? The gas gangrene. Gas gangrene. So in wet or in moist, we are talking about what? A swelling or something that is swelling, or there's what? Edema. Something that is rotten and is black. That is what? Moist. So if you think of black, rotten, and it is edematous, you are thinking of a wet gangrene. A wet gangrene. A wet gangrene. Or a moist gangrene. So basically, that is what comes to mind. In dry, like the name suggests, it is definitely what? Dry. It is definitely what? Dry. And people with diabetes, they normal about 80% of them will eventually, if the diabetes is not controlled properly, they can have this sort of what? Moist gangrene. So here, your answer is D, moist gangrene. Now, infarction also means necrosis. But infarction is normally the term that is normally referred to the heart. That's what we have myocardial infarction. What it means is that we have what? Necrosis of the heart. Necrosis of the myocardium. We call it myocardial infarction. But in the foot or in the lower extremities, we call it gangrene. Okay. A denaturation of proteins can be found in some substances. Specify the substance that is used for incomplete denaturation of hemoglobin. So first of all, what is denaturation? Now, denaturation is simply a process in which proteins or nucleic acid lose their structure. They lose their structure. And how do they lose their structure? Either there's a stress or external stress on it, or strong acid or base have been used, or radiation or heat has been applied to them. So they begin to lose their structure and, return back to nothing. So that is what denaturation of protein. In other words, destroying the proteins. And one of the substances here that is used to denature proteins incompletely is urea. It's urea. You know a lot about urea by now. It's urea. It's urea. Good. Now, during surgery, a 17-year-old patient, surgery in a 17-year-old patient, it was revealed that there is tumor of this size on the lower surface of the liver with subserous localization of dark red color. Now, if you see dark red color, what comes to mind? Of course, blood comes to mind. Blood comes to mind. Now, on the section of the tumor has cavities with marked amount of blood. You see, there's marked amount of blood. Now, the question now is that what is the primary what or preliminary diagnosis? What is the preliminary diagnosis? So definitely we are referring to what? To a vascular tumor. When we say vascular tumor, a vessel that has undergone what? Tumor. That's why we can have that kind of large amount of what? Blood being collected in the lesion. And that is called what? Hemangioma. So hemangioma is simply what? It's a form of tumor or a vascular tumor where there's a collection of what? Blood vessel. There's a collection of what? Blood in a dilated vessel. Collection of blood in a dilated vessel. In a dilated vessel. So basically, that is what comes to mind. But look at it. They say the surgery was done at it is found at the lower surface of the liver. The lower surface of the liver. Now, I don't understand why they said this is what a cavernous hemangioma. Because if you refer to a cavernous hemangioma, you are most of the time you are referring to the brain. You are referring to the brain because that's to do the connection with the brain. But this is not really a tumor of the brain. It's a tumor inside the liver or the lower surface of the liver. So I don't know why they said this is a cavernous hemangioma. But of course, Yeah, so basically, I don't know. So maybe they are showing to the cavernous as, how do you call it? The fact that cavernous also means a vessel. It also means a blood vessel. So this is a cavernous what hemangioma, meaning it is a vascular origin, but this is normally connected to the brain or the cavernous vessels. You are thinking about the brain. But over here, they are saying that is the answer. I don't know why it is so. Because me, I'm not even finding the answer, but they said that is the answer. So here, of course, we will still stick with it. We will stick with it. We will stick with it as a cavernous hemangioma. But I will try and then look at the correlation between these two of the liver and then this cavernous hemangiomas. I'll look at the two and then I'll put it on the group page for us to learn more about it. Learn more about it. I don't know why they are choosing that as their answer. Okay. So we shall come to this question later on in the distance. So someone should take a picture of it. I will search on it. All right. So we have a sick man with high temperature and a lot of tiny wounds on the body has been admitted to the hospital. Guys, look at this. There's lice has been found in the fold of his clothing. What disease? You remember when we talked about biochemistry? We talked about typhus, not typhoid fever, typhus. We spoke about what? Typhus. That's what epidemic typhus. We say it is a form of what? Typhus because it is often as a result of what? Epidemics in war or in natural what? Disasters. That's when you see this disease what? Happening. And the causative agent is what? Rickettsia. The causative agent is what? Rickettsia. And rickettsia are carried out or their intermediate host is the body louse. And the plural form of louse is lice. It's lice. And this one can be affecting human beings as well. So here we are thinking of what? Epidemic typhus. Epidemic typhus. We have already done it. So please, if you know what the video, kindly review it. Kindly review it. All right. On autopsy, it is revealed that kidneys are enlarged. Guys, look, kidneys are enlarged. The surface is large granular, because of what? Multiple cavities. That means a lot of what? Cavities. And in this, how do you call it? In medicine, a lot of cavities, we call it what? Cyst. A cavity is called a cyst. Multiple what? Polycyst. So just like it is, a lot of cysts were in the kidney. And these cysts are filled with what? Clear fluid. And I said a clear fluid simply means what? A serous fluid, right? Yes. Clear fluid simply means a serous fluid. So what kidney disease? Of course, polycystic kidney. That means many cysts or multiple cysts kidney, or kidney of multiple cysts, also known as polycystic kidney. That's why I say sometimes your answer is in the question. So your answer is A. On autopsy, it is revealed that an enlarged, dense right lung, fibrin layers on the pleura, lung tissue is light green color on incision with muddy liquid exudate. What lung disease are these symptoms typical for? What are these things typical for? So first of all, you must know that there is an inflammation of the small air sacs known as the what? The alveoli. There is an inflammation of the small air sacs, also known as what? The alveoli. Now look at the X representation. They are telling us that the lung tissue is what? Light green on excision. And this is typical for lobar pneumonia. I repeat, it is typical for what? Lobar pneumonia. Typical for lobar pneumonia. And usually it comes with a signs of what? Consolidation. I don't know if it was here that I established that by any time you see signs of consolidation, of course, over here, they didn't write any signs of consolidation over here. But you must know that pneumonias or lobar pneumonia comes with signs of what? Consolidation. Comes with fever, comes with diminished breath sounds, comes with dullness on percussion, and so on and so forth. So here, this lung tissue showing this light green color on excision with a lot of fluid exudate signify we're having what? A lobar pneumonia. Lobar pneumonia. And the lobar pneumonia in this thing is also called lung fever. Lung fever. So lung fever actually means what? Pneumonia. Lung fever actually means pneumonia. Means pneumonia. So here we'll go in for B. All right. We have on autopsy, it was revealed arachnoid membrane of the upper part of the cerebral hemisphere is pletoric, yellowish, greenish, green color, soaked with purulent fibrous exudate. So first of all, you know what the arachnoid is, the another space is all about. That is where you find cerebrospinal fluid. Cerebrospinal fluid. And in cerebrospinal fluid, it is devoid of infections. It is devoid of plenty cells. It is devoid. When I say devoid, it is without blood, without pulse, whatever it is. We don't have to see them in the cerebrospinal fluid. When we see them, we will start having signs of meningism. I repeat, we will start having signs of meningism. When I say meningism, that's when they begin to have nerve stiffness. Your nerve becomes very stiff. You begin to have headaches. You're having hospital pains. You're having this Babinski, Brzezinski signs. All these are all what? Signs of meningism. Signs of meningism. Signs of meningism. But look at it over here. We are having all these being present. That means already there are signs of what? Meningism that can what? Develop. Of course, they didn't tell us the signs, they're only telling us what? The morphology. The morphology. So we have what? Pletoric, yellowish, green color, soaked with purulent, looks like a cap. What disease is characteristic of this picture? So basically, you are thinking of this as meningococcal meningitis. Now, in pathophysiology or in physiology, you will see that they will have added that it is preceded with what? Rash. So this person comes with what? Rash. Rash. And it occurs in children a lot. Occurs in children a lot. But of course, this is what? Morphology. It's morphology. And yeah, so basically we are thinking of what? Meningitis. Meningitis. Now, in tuberculous meningitis, of course, there will be a history of what? Tuberculosis. There will be a history of tuberculosis being present, or mycobacterium tuberculosis will be what? Will be present in the anamnesis. But over here, nothing like that. So our best bet will be what? Meningococcal meningitis. Meningococcal meningitis. So here your answer is A. Your answer is A. All right. Good. Autopsy of the 8-year-old man revealed bicuspid valve was deformed, thickened, and unclosed. Microscopically, there's what? Foci of collagen fibrilla are eosinophilic. React positively to fibrin. What is the most probable, or the most probable it is what? Look at it. There's what? The reaction to fibrin is positive. Is positive. Now, due to the positive fibrin reaction and the fact that there is what? Eosinophilia of the collagen fibers, it is better for us. So definitely you're thinking of either fibrinoid swelling or fibrinoid what? Inflammation, isn't it? But due to the above thing that I've just said, that is like positive fibrin reaction and the eosinophilia of the collagen fibers, we should rather go in for what? Fibrinoid swelling. Fibrinoid swelling. Since there's no record of any inflammatory reaction. There's no thing of inflammatory reaction. In inflammatory reaction, there will be presence of what? Neutrophilic or neutrophilia. Neutrophilia, that's white blood cells. Neutrophilia. But there's no signs of neutrophilia present, but rather we are talking about eosinophilic. So here we can go in more with the swelling than the inflammation, although technically they all will lead to swelling eventually. All of them. Inflammation will lead to swelling too. But this is morphology, so you have to understand the clear differences between them. So here we are going for A. Good. Chronic inflammation and transformation of one ciliated epithelium to multiple layers. So what it means is that there's a transformation of one differentiated cell to another differentiated cell. And that is just a term. And the term is called what? Metaplasia. So metaplasia is the transformation of one differentiated cell type to another differentiated cell type. And over here, we are having what? One layer ciliated epithelium into a multiple layers of flat epithelium. Please take note. Metaplasia. We will see a similar question like that again. All right. For a long time, a 49-year-old woman was suffering from glomerulonephritis, which caused her death. Autopsy revealed the kidneys size was this, weight is that, and they are dense and small grained. Microscopically, fibrinogenous inflammation of serous. When I say serous, it means what? It means it's clear, right? But there are serous and mucous capsules, dystrophic changes of parenchymatous organs, brain edema. There's brain edema as well. What complication cause such changes of the serous capsules and the inner organs? Now, don't forget, this person is suffering from what? Glomerulonephritis. And one of the complications of chronic glomerulonephritis is what? Is kidney failure. And when there's a kidney failure, and look at this, you see that's what they've always told you, that the kidney revealed their size. 7 by 2 by 2.5, weight is 65, dense and small what? Grain. Small grain. That means they are kind of what? Small. That means they are going through what? Kidney failure. And again, they've told you this person suffering from what? Glomerulonephritis for a very long time. So what it means is that this patient might have developed what? Kidney failure. And in kidney failure, what happens in the blood? In kidney failure, it is accompanied with uremia. It is accompanied with uremia. And a uremia is the condition of having high level of urea in the blood. And you know urea are normally what? Excreted, isn't it? But if you have high amount of urea in the body, definitely it means the kidney is not performing its function as it's supposed to. And in this case, this patient is suffering from what? A kidney failure due to the chronic or the suffering from glomerulonephritis for a very long time. So here we are thinking of uremia as the reason for all these what? Changes. The reasons for all these changes. A patient died under condition of cardiovascular insufficiency. When we say cardiovascular insufficiency, it means the heart cannot really what? Meet the demands of the body, isn't it? Autopsy results shows what? Post-infarction cardiosclerosis. Again, that goes on to confirm that there's what? Cardiac or there's cardiovascular what? Insufficiency. Look at it. There's myocardium hypertrophy. That means it has become big. There's dilatation of 8 cavities, especially its right ventricle. Okay? Its right ventricle. Then the liver is enlarged. Surface is smooth. Incision revealed that it was what? Plethoric, with dark red specks against the background of brownish what? Tissue. Against the background of brownish tissue. But look at something over here, histologically. Look at something. They said the hepatocyte is in a state of adipose degeneration. Adipose degeneration. And what are these liver changes? That means the question does not have to do with the heart. The question wants to talk about the liver. The liver what changes. So what is happening in the liver? So this one we have what we call a congestive hepatopathy. Congestive hepatopathy. That means congestive what? Liver or liver disease, also known as nutmeg liver. Also known as nutmeg liver. Nutmeg liver. So over here, there's what? There's a dysfunction of the liver as a result of poor venous or as a result of venous congestion. Now, they've already told us that this person is having what? Cardiac insufficiency. That means the heart is not able to what? To work very well. So if the heart is not able to work very well, what it means is that venous blood that is entering into the right heart might not be able to go again. So as a result, they will congest in the liver. They will congest in the liver because it's not able to pass through the the inferior vena cava. And you notice the inferior vena cava that sends venous blood into the heart. Good. So it is a problem with the heart. That means the heart cannot work properly. It cannot work properly. So as a result, that's why we call it what? Congestive hepatopathy. Hepatopathy. That means there's congestion in the liver. And that is also known as what? Nutmeg liver. Nutmeg liver. Nutmeg liver. So here we are thinking of what? Nutmeg or congestive hepatopathy. Congestive hepatopathy. Okay. We have a 59-year-old man, signs of parenchymatous jaundice and portal hypertension. On a historical examination, the puncture of the liver biopsy, it was revealed beam-lobule structure is affected. Part of the hepatocyte has signs of fat dystrophy, portal congestive tissue septa with formation of pseudo-labules. Then we have periportal lymphomicrophage infiltration. What are we thinking about? What are we thinking about? See, all this liver, or what the liver is trying to tell us is that, the analysis is trying to tell us that gradually the hepatocytes in the liver are becoming what? Are turning into fibrous tissue, or they're beginning to get what? Scarred, or it is what? Scarring. So it is going to a chronic disease. It is going to what? A chronic disease. So that means the normal hepatocytes are being replaced by what? By fibrous tissues. They are being what? Replaced. They are being what? Replaced. That's what they're telling us, that the hepatocytes are having signs of fat dystrophy. That means destruction of the fat. Portal connective tissue septa with formation of pseudo, they're not lobules, but they are like lobules. And lymphomicrophage infiltration. Lymphomicrophage infiltration. So that means everything is becoming what? Distorted. Everything is becoming irregularly shaped. Everything is becoming scarce. That's SCARS. Scarce. Scarce. So the active liver cells is undergoing what? Necrosis. Active liver cell necrosis is undergoing in this what? Patient. And the term for it is what? Or the term whereby the hepatocyte or the normal cells of the liver are being replaced with scar tissue or with fibrous tissue. We'll call it what? Liver cirrhosis. Liver cirrhosis, which is the kind of the final stage of liver disease. The final stage of liver disease. The final stage of liver disease. So here we are talking about what? About E. About E. About E. Okay. Good. This one, I don't need to worry your head too much about this particular question because it's actually easy to remember. Why? Because of Steinbeck cells. However, the question says what? Microscopic examination of the enlarged neck gland of a 14-year-old girl revealed destruction of the tissue structures, absence of lymph follicles, sclerotic areas, necrosis foci. Cell constitution of the node is polymorphous, lymphocyte, eosinophils, big atypical cells. And this is same as what? Steinbeck cells. Steinbeck cells. And Steinbeck cells simply means what? There's what? How do you call it? Lymphogranulomatosis. It means lymphogranulomatosis. In other questions, in other options, you will see Hopkins disease, Hopkins disease, Hopkins disease. So this is just a disorder involving primarily the lymphoid tissue, primarily the lymphoid tissue. So that if you don't see Beresovsky Steinbeck cells, you will see red Steinbeck cells, red Steinbeck cells. That's REED, Steinbeck cells, red Steinbeck cells. They all mean Hodgkin's disease or lymphogranulomatosis, lymphogranulomatosis. All right. So here your answer is what is E. I know I've explained the chronic leukocytosis and then the acute and chronic lympholeukosis to you guys in the previous lectures. So I won't talk too much about it again. But that's when you have to think of smudged cells. You are thinking of lymphocytes that's more than 20% in the blood. So all of this shows that there's a lot of what. So basically, they are referring to leukemias. They are referring to what? Leukemias, either of myeloid origin or of what? The lymphoid origin. So when we get a question like that, we'll discuss it. All right. We're having a female patient suffering from bronchial asthma. I have a question on bronchial asthma. You people should just get it right once and for all. Now, he got viral infection that provoked status asthmaticus with fatal outcome. Histological examination of the lungs revealed spasm and edema of the bronchioles, apparent infiltration of their walls with lymphocyte, eosinophils, and other leukocytes. There's labrocyte degranulation. The question is, what mechanism of hypersensitivity is it? We've talked about bronchial asthma before. We said it's what? It's an immediate type of what? Hypersensitivity or atopic hypersensitivity or ranging reaction or ranging hypersensitivity. We talked about all of these names that are given to what? Immediate type of what? Hypersensitivity or type 1 hypersensitivity. It is also called anaphylaxis. So all these terms are referring to the same thing. So again, we have atopic, we have ranging, we have immediate, we have what? Anaphylaxis. All these are referring to what? Bronchial asthma. We've done them already. That's why I don't want to talk much about it. Please do well to watch all those videos. Do well to watch them. Now, autopsy of a 40-year-old woman who had been suffering from rheumatoid arthritis. Her liver is found to be dense and enlarged. Now, on dissection, its tissue is red-brown colored and enlarged follicles resembling, guys, this is your clue. Resembling semi-transparent grayish-white granules. Semi-transparent grayish-white granules. And this is the same as what? Sago. This is the same as what? Sago spleen. This is the same as sago spleen. This is the same as what? sago spleen. So a sago spleen is simply a spleen which is affected with what? Amyloid degenerations. Amyloid degenerations, in which the amyloid is deposited in the myophagine corpuscles, which appear in a cross section as a gray translucent bodies. Gray translucent bodies resembling grays of sago. Resembling grays of sago. And that's what the name comes from. Sago spleen, because it's resembling the grays of what? Sago. A gray translucent bodies. Gray translucent bodies. So here we are thinking of a sago spleen. Again, a sago spleen is a spleen which is affected with amyloid degeneration. That's amyloidosis. Good. Amyloid degenerations. And these amyloid is deposited in the myophagine corpuscles. Now, myophagine corpuscles is part of the spleen. That's anatomy. I can't teach that. So it's part of the spleen. So because these, and don't forget, amyloid are sort of proteins, okay? They are more like protein. In fact, they are proteins. Okay, they are proteins. So these proteins get accumulated in the myophagine corpuscles, and then on cross, if you cut it, it begins to look like a gray translucent bodies. So that's where the name sago comes from. So here, your answer is what? Sago spleen. Sago spleen. Local lymph nodules enlarged near the infected wound. Increased amount of macrophages, lymphocyte, lymphatic follicles in the cortical layer, and large amount of plasma cells were revealed on histological examination. What process in the lymphatic nodules represent these histological changes? Good, look at it. There's what? Lymph nodes enlargement near a wound. There's increased amount of macrophages, lymphocytes. So what will cause an increase in macrophages, lymphocyte, and so on and so forth? Is when there's what? There's a reaction, or when an antibody is reacting to what? To an antigen, isn't it? So this is called what? Antigen stimulation. So antigen has caused a stimulation in the body. That is why the immune system is trying to engulf, react, and kill the antigen. So this is called what? Antigen stimulation. What is antigen? Antigen is simply a substance that is capable of stimulating an immune response. Stimulating an immune response. And if you look at it over here, the immune has responded. Why? Because of the presence of what? An infection or an antigen. An antigen. An antigen. All right. So here we are talking of what? Antigen stimulation. Antigen stimulation. On autopsy of the man with alcohol abuse, look, alcohol abuse. I don't know if I've said it over here before, but I know I've spoken to a group of people. Anytime you think of alcohol, think of 2-3 places. Number one, you are thinking of a problem with the liver. Number two, you are thinking of a problem with the brain. Or you are thinking of what? A withdrawal syndrome or withdrawal symptoms. Or you're even thinking of, how do you call it? How can I forget this thing? Oh, I forgot. When I remember, I will bring it up. But you're thinking of these basic stuff. The liver disease, you're thinking of what? A brain, you're thinking of a withdrawal syndrome. And you're thinking of what? Tremors. You are thinking of tremors when there's a withdrawal what? Syndrome, or when there's abstinence from the medication. So look at it over here. So on autopsy, a man with alcohol abuse for a long time it was revealed. Then small, knobby, small sized liver. Microscopically, there's pseudo-labules divided with thin layers of connective tissue with macrophagia infiltrate, hepatocyte in the state of globular fatty dystrophy. Globular fatty dystrophy. So what is happening over here? What it means is that the liver is, or the hepatocytes are being replaced. The hepatocytes are being what? Replaced. And the hepatocytes are being replaced again. We are referring to what? Cirrhosis. Cirrhosis. But this is of alcohol origin. So this one is actually what? Alcohol liver cirrhosis, or alcohol liver cirrhosis. Alcohol liver cirrhosis. You're thinking of what? B, liver cirrhosis, or alcohol cirrhosis. Alcohol cirrhosis. All right. We have an 8-year-old child who was admitted to the infectious department with fever and pointed bright red skin rash. Child was diagnosed with scarlet fever. Scarlet fever. Objectively, mucous membrane of the pharynx is apparently hyperemic and edematic. Tonsils are enlarged, have dull, yellowish-gray foci with some black areas. What inflammation is the reason for the pharynx changes or the pharynx alteration? So usually, scarlet fever is characterized by either catarrhal or necrotic tonsillitis. Again, scarlet fever is characterized by either catarrhal or necrotic tonsillitis. Now, in catarrhal, it is manifested by hyperemia of the pharynx. Hyperemia of the what? Pharynx, with involvement of the oral cavity and the tongue. Good. Again, catarrhal is manifested by hyperemia of the pharynx, with involvement of the oral cavity and the tongue. And usually it will present with a strawberry appearance. A strawberry appearance. Strawberry appearance. Good. So write it down. Now, in necrotic tonsillitis, it is characterized by coagulative necrosis and ulceration. Coagulative necrosis or ulceration. 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 Now look at this question. Now, microscopically in this question, there is what? An acute edematous. It is acute edematous, neutrophilic. Now, when we say neutrophilic, we're definitely referring to what? To a purulent, or the fact that there's what? A yellowish gray foci means what? It is what? Purulent. Purulent. It means it is what? Purulent. It is purulent. Purulent. So that is the reason why over here we're easily going for what? A purulent what? Necrosis, or a purulent necrotic. Purulent necrotic. That's simply to tell us that this is what? A necrotic tonsillitis. A necrotic tonsillitis, rather than what? A catarrhal tonsillitis or a catarrhal scarlet fever. In catarrhal, we're having what? A strawberry appearance. Strawberry appearance. But that is not what is seen in this patient objectively. So here we are thinking of what? A purulent necrosis or necrotic. Okay. A 30-year-old patient was bacteriologically proved what? Dysentery. Developed the sense of what? Paraproctitis. What stage of local changes is in this patient? Again, what is dysentery? Dysentery is simply what? An intestinal inflammation, primarily of the colon. Primarily of the colon. Now, morphologically, dysenteric colitis has 4 stages. If I were you, I will write this down. Morphologically, it has 4 stages. 4 stages. We have catarrhal, fibrinous, ulcer formation, and healing. Again, 4 stages. We have catarrhal, fibrinous, ulcer formation, and healing of the wound. Healing of the wound. So now what then is what? Paraproctitis. Paraproctitis. Now, paraproctitis is simply what? A purulent inflammation of the cellular tissue surrounding the rectum. A paraproctitis is simply a purulent inflammation of the cellular tissue surrounding the rectum. Surrounding the rectum. Surrounding the rectum. Now, with this, we can easily say that this is of what? Of ulcer stage, because ulcer is forming because there's what? An inflammatory what? Reaction. Or yes, probably, yeah, definitely purulent what? Inflammation of the cellular what? Tissue. And that means that the place is going through what? Ulceration. The place is going through ulceration. 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 That is why over here we can easily go in for what? Ulceration stage or ulceration of the dysentery. The dysentery. All right. Good. I love this question because we've talked about it already. Now look at this question. A patient who has been abusing tobacco for a long time has got cough accompanied by excretion of viscous mucus. There's weakness of minor physical stress and there's pale skin. Patient has also lost 12 kg of body weight. Look at the endoscopy of the biopsy. His illness was diagnosed as squamous cell carcinoma. Squamous cell carcinoma. Now, name a pathological process that precedes the formation of this tissue. That means the normal lining has changed to what? To squamous cell carcinoma. To squamous cell carcinoma. And we said again, when a cell has differentiated from one cell type to another, we call it what? We call it metaplasia. That's why I said I love this question because it's the same thing. Because of his smoking attitude, the epithelial tissues has changed to squamous cell carcinoma. It has changed, or it has that's it. It has changed. All right. So here we're having what? Metaplasia. Again, look at this lovely question. This one, you guys should just close your eyes and answer this question. Diagnosis scraping was performed to a woman with dysfunctional uterine bleeding. Guys, look, multiple convoluted glands. What does it mean? It means more glands. Ganglially dilated cavities. The question is, what is the name of this general pathological process? We have already talked about it. This is what? Glandular ganglionic hyperplasia. The answer is in the question. The answer is in the question. Glandular ganglionic hyperplasia. Hyperplasia. So here you are thinking of what? Of A as your likely what? Answer or pathologic process.